Thanks for having me here, sharing some of my work I'm doing on data mining, clinical decision support out of the electronic medical record. Let's set a little bit of background first on why we even care about such a thing. Why would we even need such a thing? So before I went to medical school, I had this impression that if you just go to the doctor and the doctor tells you something, they're basically right. You know, that's why you went to them. They're going to tell you the right information. Instead, if you actually look at the practice of medicine today, it's actually marked by distinct and extreme clinical practice variability, something I didn't really realize until I went through my own medical training. Right, if you're just one person with one disease and you show up at 10 different hospitals in the nation, you could very easily end up with 10 different courses of treatment. And that's going to compromise both your quality and your cost efficiency of your healthcare. Now, to be fair, a lot of that variability is actually due to uncertainty. Right, here's a dirty little secret about evidence-based medicine. For the vast majority of medical decisions we make on a daily basis, there is no good evidence to tell you what to do. Right, how many clinical practice guideline recommendations are actually based on high quality level A evidence? It's like 11%. Half of them are basically expert opinion. If you hear that, well, you might argue, well, all that really means is you just need to do more research. Do more research, fund some more clinical trials. Eventually, we'll have an answer to every possible medical question you possibly have, and then we'll be basically done. I actually think that's fundamentally impossible given the dynamic and combinatorial nature of medicine, but let's just say for argument's sake you can do that. Just do more research and you know the answer to everything. This is kind of from a joke article from the New England Journal published many years ago, where the guy here is literally taking the weight of medical knowledge. He's weighing on a scale the Index Medicus. It's kind of the precursor to PubMed. And he laments there's an exponential growth in the weight of medical knowledge that we are responsible for. And now when there are more than 75 randomized controlled trials and over 11 systematic reviews being published every single day, well, I don't know about the rest of y'all, but I am way behind in terms of keeping up with the literature. The complexity of modern medicine far exceeds the capacity of the unaided expert mind. So this became very real for me when I was learning how to be a doctor, taking care of patients in the hospital, encountered a situation I wasn't sure about what to do. Well, what could I do instead of just taking a guess? Well, actually, the reality is what I do is I probably ask another doctor. I work in Stanford and many expert clinicians here. This doctor sure seems smart. I'll just ask her, hey, what would you do for this patient? I want to learn from you. Although doing that enough times, it got me thinking, you know what I really wish? I wish I could kind of forgo the privacy laws. The next time I encounter a patient where it's not clear what to do, I could just go see with that doctor, look in her charts, because I bet she's taking care of somebody like this, and I bet I could learn from that how to take care of my own patient. Although running with that idea further, why should I just look at one doctor's charts? Why don't I look at the last 1,000 doctors' charts? I bet I can learn even more from that. Although thinking about that further, that idea I just described, that is basically what a recommender system does. Collaborative filtering, market basket analysis. You bought this book on Amazon. Well, other people bought this book. Maybe you'll like it too. So very broadly speaking, what my interest has been is to see if such an approach can be applied to clinical decision making and thus uniquely tie together both the afferent and efferent limbs of a learning healthcare system. But of course, open questions remains on whether doing so is going to be predictive of real clinical practices, outcomes, and align with established standards of care. So let's find out. This is how we're going to go proceeding there. So how do I go about doing that? First, if we're going to do anything, we need the data. So I went to Stanford Hospital, and I said, I want to see for every patient who's ever hospitalized at Stanford, I particularly want to see the clinical orders. So this is the doctor's orders for your lab tests, your imaging, your medications. Eventually, I rolled in things like lab results and diagnosis codes, but it was really the orders that I cared about, because often as I would teach my own interns nowadays, I would say, look, you can write a 10-page history and physical note, or you could write nothing, and it almost doesn't matter. At the end of the day, the only thing that counts is what did you decide to order for your patient. That is the concrete manifestation of your clinical decision making. With that in mind, I did a better pre-processing so that each patient's data, this would be like one example patient's data, it's just a labeled event of time, a timeline of labeled events that's happening for the patient. Again, it's mostly orders that I'm interested in. And once you've laid out the data this way, it then becomes very easy to ask co-occurrence questions. And I did it this way because this is basically how Amazon's item recommendation algorithm is published, exactly the way they approach it. So then you could ask, for example, somebody who gets an EKG, how often does that happen that they get an X-ray ordered within 1 hour? That becomes very easy to ask that question now, right? Well, now let's just systematically ask that question for all pairwise combinations of possible items. You drop those numbers into a 2x2 contingency table from which you can then derive several association statistics like sensitivity, specificity, relative risk, etc. Some of the other statistics which you can derive, things like support, confidence, lift, and interest, this actually comes from the Market Basket Association literature, which, just to make sure we're on the same page, what is this market basket thing I keep talking about? So when you go to the supermarket, you can get a club card, right? And they will give you free discounts on your groceries if you do this. So why are they doing that? Those discounts are not free. What they're doing is they're using that to keep track of what you're buying now and over time. And then, for example, some of the classic anecdotes here is one supermarket found that people buy beer and diapers together much more than you'd expect by random chance. Now you can imagine if you're the store manager, now you can do a strategic decision. Put all your diapers in the back of the store and put your really expensive alcohol right in front of it, maybe encourage some impulse buys. This was another interesting article from the New York Times a few years back, where they had another colorful story where targeted product algorithm ended up starting advertisements to a teenage girl about pregnancy-related products. And basically, what was happening was the algorithm had figured out that this teenage girl was pregnant even before her own father had, just based on the kinds of things that she was purchasing. Let's go back to a clinical example. So with those in mind, I basically prototyped this concept, but for clinical orders in the hospital. So for example, these are the clinical orders that are disproportionately likely to occur for patients admitted for chest pain to Stanford Hospital. Right, so the top one, point-of-care troponin, that makes sense. This is a blood test to see if you're having a heart attack. And with each of these, we can have a set of statistics that are reported with them. For example, the prevalence, that's kind of your pre-test probability. Forget chest pain, just overall about 16% of patients in the hospital get that blood test. Compare that to positive predictive value, that's kind of your post-test probability. Given that you're admitted for chest pain at Stanford, about 71% of such patients got that blood test. That works out to about 14 times the odds, a tiny, tiny p-value suggesting there's something very significantly associated about that order with this clinical context. Other things that pop up, the system thinks maybe you should get an EKG, again, electroactivity, see if you're having a heart attack. If you're having anginal pain, nitroglycerin to ease the pain, call cardiology for help, give them an aspirin in case they're having a heart attack, take them to cardiac cath to try to fix the problem. If you're not sure what's going on, do a dobutamine stress echo to risk stratify. So a couple of things I want to reinforce here is that at no time did I ever sit down and try to design an order set, a collection of things that you should do for chest pain or a heart attack. I didn't do a review of the literature to look up what the medications and diagnostic tests are. This is all information that just naturally grows out of the clinical data itself, right? Because each doctor is already trying to figure out the best way to take care of the patient. All we are is kind of observing and taking advantage of that behavior and leveraging that. So a lot of different ways this can go, but for the sake of time, I'm also going to hone in on some qualitative aspects. I mean, qualitative, I can show you that and many other examples. I'm going to show you a few more where it looks good to me. It makes sense to me. As a doctor, I can read those orders and I get what's happening. I get what the system is trying to do. But this is also the point of the talk where I have to get ready to start dodging some tomatoes because people are getting worried about appropriately worried about how this could also go very, very wrong. So a couple of the concerns with an approach like this. Would doing this just tend to lead to overutilization? I would actually say probably yes, the way I framed it, right? When Amazon recommends you a book, I mean, really all they want you to do is just buy more stuff. But that's not what we're trying to do in medical practice. What I would say to that is you could just as easily just frame this in the negative use case. I've just focused on the positive use case. Hey, before you order that back MRI, doctor, did you know that only 10% of other doctors would do so in a similar situation? And furthermore, did you know that only 2% of those patients ended up getting surgery that actually affected them? That doesn't tell you whether it's a right or wrong decision, but that's much more specific information you can think about before making potentially a low yield decision. Really, those points to a bigger conceptual problem, which is, in some sense, one of the whole key themes that I'm trying to go after. When it comes down to whether or not you believe in the wisdom of the crowd, or do you fear the tyranny of the mob, right? Because just because something is common, it doesn't mean that it's actually good. It turns out this is actually extremely hard to prove or disprove because there's no such thing as a gold standard to define what good medical decision making is. So a lot of my work actually has been trying to unravel that and unpack that and trying to figure out how much we can determine. So one way to go about it, ideally you would say, don't recommend me what's common, recommend me what leads to a better patient outcome. That turns out statistically very hard to do because of a causal inference problem, which we can get into. But if even one step in that direction, if I want to make suggestions going to lead to better outcomes, I'd better at least be able to predict what your outcome is going to be. So I went ahead and looked at things like whether you're going to die within 30 days, end up in the ICU, or whether you're going to get discharged or readmitted to the hospital. Because if we can come up with a system that suggests the chance that you're going to order a troponin blood test, well, I can do the same thing for any of these outcomes, right? As far as the system's concerned, it's just another labeled event in the patient timeline. It doesn't even think anything's different about it. So with very little incremental effort, it turns out we can get accuracy scores for these outcome predictions that are on par with even state-of-the-art prognosis scores that used to take decades of work to develop in the past. But another way to think about it then is, there's no overt gold standard, but at least is there some other external reference standard that I can compare against to see if such approaches to knowledge and information retrieval could actually be compared against. So in this case, I look to clinical practice guidelines. So these are documents put together by bodies of experts. The American Heart Association tells you how to take care of a heart attack, basically, based on their experts review the literature and their expert opinion, basically. Of course, this is still not simple and straightforward to do. By design, these guidelines, these things that really doctors, their job is to learn how these work, what's in the gum, and how to apply them to their patient. By design, they are vague and open to interpretation. Right, so these are some of the guidelines for somebody has a GI bleed. If you're vomiting blood or pooping blood, the guidelines say, hey, maybe you should get an intravenous proton pump inhibitor. Well, at Stanford Hospital, that's actually pretty easy. That means an IV pantoprazole infusion. That's a guideline appropriate order. Check. I count that as guideline appropriate. Let's look at this next suggestion. Perform hemodynamic status assessment and appropriate resuscitation. That's a strong recommendation. Well, okay, but what is the clinical order that maps to? What is the concrete decision as a doctor I'm supposed to do that fulfills that suggestion? So this is really like where I have to kind of take my data science hat off, put my MD hat on, and say, well, I think if the doctor orders a troponin and a lactate, what they're trying to do is hemodynamic status assessment. If they order a bolus of IV fluids, what they're trying to do is resuscitation. Even though the guidelines never said any of those words, I'm putting that clinical interpretation in there. Another situation you have is like implied orders. So if you have a lower GI bleed or poop in the blood, guidelines say consider a colonoscopy. Pretty easy, colonoscopy procedure, I'm counting that guideline appropriate. But implied there is, in order to get a colonoscopy, for one thing, you have to be NPO, you're not allowed to eat anything. And number two, you need a bowel prep. So you drink a big jug of electrolyte fluid, give yourself diarrhea, flush out your colon. Again, the guidelines never said those words, but I'm going to count those as guideline appropriate because you couldn't do the thing that was suggested unless you did those steps first. So all that work, where does that get to us? This is the top orders for the admission diagnosis of chest pain, the exact same thing I showed you before, but now we have two additional columns of information. They're binary labels. So one is, did this order was mentioned in the hospital's manually authored order sets for decision support for chest pain? And the last one is kind of our outcome label, whether the guidelines ever mentioned that order is something reasonable to consider in this clinical context. And if you have a column of scores next to a column of binary outcome labels, what you can do is a receiver operating curve. This came out blurry for some reason, but it's enough to show that the simple point I'm trying to make there is using one of these score-based order suggestion ranking systems is as good, if not maybe even better, than using the hospital committee's manually authored decision support for this clinical context in terms of aligning with the clinical practice guidelines. This trend holds similarly true for, say, if someone's admitted for pneumonia, the system thinks maybe you should order some blood cultures and antibiotics. Or if the patient has a GI bleed, they're vomiting blood or pooping blood, the system thinks maybe you should order an antacid infusion to suppress the bleeding, call a gastroenterologist for help. There's that bowel prep to flush out the colon if you need to, do an upper endoscopy to fix the problem, transfuse some blood in the meantime to try to keep the patient alive. Now I blitz through these results very quickly because the point here is not, hey, look, I made a better template, a better order set, a checklist for GI bleed and pneumonia. Maybe I did, but even if I did, the hospital already has an order set for chest pain. We already have a template for that. We already have a guideline for pneumonia. What I think is far more compelling is when we can extrapolate to scenarios like, say, patients admitted for altered mental status. So this is a classic medicine admissions. Often it's like a nursing home patient, progressively sleepy or confused for no good reason. Nobody knows what's going on. So they send them to the hospital. Well, in this case, the hospital has no predefined order set, checklist, or templates that you can work off of. And I've looked. There is no clinical practice guideline that tells you what to do in this case either. So, but you still got to take care of the patient in front of you. You can't just say, well, there's no evidence, so I guess I don't do anything. You got to figure out how to take care of the patient in front of you. So what can you do? Well, there's nothing else you can do. You have to just make up some orders off the top of your head. Or you say, the last time I admitted an altered patient 5 months ago, I think I did these 5 things, and that patient didn't die. So I guess good choices. Or you say, really in practice, what you tend to do is you would phone a friend. Hey, neurology, psychiatry consult, I got an altered patient here. Hey, what would you do if this were your patient? Or what if technology like I described was available and our physicians can make their medical decisions informed by the collective experience of thousands of other physicians right at the point of care? Leave you to ponder that thought, acknowledge different funding sources, mentors, data sources, students who have helped make this work possible. Most of all, to all of you, though, for your attention today. Thank you very much. Glad to take your time.